lecture is part 2 of Image Gently's Using Exposure Indicators to Improve Pediatric Digital Radiography. To recap the objectives of this lecture, in part 2 we're really going to focus on the bottom bullet points, and we're going to start to break down the IEC exposure terminology standard, talk a little bit more about quality assurance, and really get into some of the different nuances of the exposure indicator systems, both of the current and of the past. In general, the exposure indicator provides immediate feedback to the technologist regarding proper radiation exposure for a specific exam. What that exposure indicator is going to represent is the relative exposure to the image receptor itself. So we're not talking really about patient dose in this case, but just how much radiation exposure is that IR actually receiving. And this is dependent on the efficiency and sensitivity of the system to those incident X-rays. So the more sensitive it is, the lower amount that you can actually use to actually produce that image. Nonetheless, without an exposure indicator, verification of appropriate exposure factor selection is really impossible for digital radiography. So it's important for us to be able to understand and recognize that cause and effect. So the exposure indicator will tell us the effect of the exposure technique that we actually select for a given exam. Historically speaking, vendor exposure indicators have been quite problematic within the field because of their different nuances. Each vendor had its own proprietary formula for how to determine what that exposure indicator was, what it meant. Some scales were linear, some scales were logarithmic. Some scales increase, their number increases with exposure, others the number decreases with added exposure. So what this really does is it creates substantial confusion for technologists, physicists, radiologists alike. So it's important that essentially you understand how your systems work in your facilities. And hopefully they have now been upgraded to incorporate the IEC standards. So as we continue to talk, we'll say, okay, here's where we were, and then here's where we are currently with the IEC standards. So you'll have a good sense of, what is likely still used in some of your clinical facilities, and then what should be used kind of going forward. So looking at this particular table here, it gives you a good idea of, in this case, 3 systems that are widely used. So 3 very popular systems. So Fuji uses an S number, Agfa uses what's called log M, and Kodak uses a EI value, exposure indicator value. Carestream also does, and Kodak and Carestream really are the same type of system, same type of formula is used there. So Kodak became Carestream in essence. So what I want you to do is to first recognize the acceptable range. And that line here is bolded so you can understand that acceptable ranges differ. What is good for that system. So when we're trying to interpret the value, the outcome, what does that really mean? And you can see how much they differ. So if facilities have more than one system, you can definitely understand why confusion would exist. But looking at this, what we're really trying to do, what the vendors determine as a acceptable exposure to the detector, really if you kind of break that number down, is 1.0 milliroentgen. So you can see that, here's the unit. So 1.0 milliroentgen is really kind of what you're striving for. But when you look at that, looking at the Agfa system, from 0.7 corresponds to 2.05, to 1.3 corresponds to 2.35. So what is that sweet spot in that case? You can see that's a 30.3 difference, so add 15. So a 2.20 is considered in this system a perfect exposure. So just kind of keep that in mind, that while that's not much deviation, to be able to say, okay, well, that's overexposure, that's substantial overexposure. So these numbers and the intervals between them are very, very small. So you have to be very careful and recognize that. In this case, you can see, again, let's look at the Fuji system. So 150 In this case, it's actually a inverse system. So 150 would correspond to 1.3 milliroentgen of exposure, where a 300 value would correspond to a 0.7 exposure. So the other thing to kind of keep in mind, while I said that 1 MR is considered a perfect exposure here, certain systems like Fuji may say that a acceptable exposure for a hand may be a little bit higher number. So there are some variances there, so just kind of keep that idea in mind as well. But what I'm just trying to elaborate on is to show you how a specific system works and then how complicated these systems actually are. In this case, with the Kodak exposure indicator system, a 2000 is considered to be ideal. And then you can see, well, 2150 would correspond to 1.3, whereas 1850 would correspond to 0.7 milliroentgen of exposure to the image receptor. So not to the patient, but to the image receptor itself. And then correspondingly, the numbers do increase with increased exposure. So understanding, well, oh yeah, it was somewhat close. What I really want you to recognize is even the range of acceptable is a double range. Double of 0.7 is 1.4. So what I would challenge is for you to actually go on the bottom side of those numbers. So the bottom side in the Fuji system is 300. The bottom side in the EGFA is 2.05. Bottom side of Kodak, 1850. So you can see what that would really look like, because ultimately we need to have an acceptable image at a lower dose. And when you look at that, well, that's double the dose to the image receptor, and it's still considered to be acceptable. So in my opinion, that's pretty wild to really think about. So we have to be really careful and understand, hey, what is actually going to be acceptable, and can we, bump it down one range and kind of go from there. So oftentimes these systems are still in place in clinical facilities, so I certainly do want you to recognize how these different systems work and be able to interpret those. This next graphic really reiterates these same types of things. So you can see that this is decreasing exposure and this is increasing exposure. So this particular scale goes from 1.25 microgray through 10 microgray, and you can see what that would correspond to in different systems. So some of those systems are, like I mentioned before, with the Kodak system, the EGFA system, and the Fuji system, but this also incorporates Philips and Siemens, so every system is different. And you can see that this is an inverse system. These two systems are considered inverse because the number gets smaller as the exposure increases. Whereas these are considered to be a direct systems, in that the number is getting larger as exposure is increasing. But again, just kind of pay attention to those different intervals, and those different acceptable ranges. So in essence, really to recap, it's important to know what your facility is using, and it's not necessarily as important to understand, how the vendor gets to understanding how their system really works. Some systems are linear, meaning that number is actually going to be directly proportional to the exposure, and others are considered to be logarithmic, meaning that adjustments in exposure may not be proportional. So that means at certain points, a very small deviation may make a very big difference, in terms of patient exposure and what those numbers mean. So I guess it is important to kind of recognize what some of those differences really look like, but it's more important to understand that each vendor has their own proprietary exposure indicators. So mentioning, again, some have direct relationships and others have inverse relationships. And in the end, what this is really going to do is it's going to result in confusion to the end users. So fortunately, there is help that's on the way. So at the present, there has been an agreement to adopt a new exposure indicator standard that for all equipment vendors, so going forward. So if your facilities are still making use of those other standards, it just means that they haven't upgraded, whether that's their software or getting new equipment. those types of things. But the new IEC standard is a part of all new equipment, and IEC stands for International Electrotechnical Commission, and the standard is specifically the number of that standard is here. So 62494-1 is what the standard is. So fortunately, in 2010, at an Image Gently summit, stakeholders agreed to adopt this unified standard. So what we're really going to walk through is how this standard really works. Some of your facilities likely already using this, and that's good because this is kind of the standard of either the present or the standard of the future, depending on how modernized your facilities actually are. But the standard utilizes three terms. So the three terms that I want you to know: exposure index, EI, target exposure index, which is EI sub T, and then deviation index, which is DI. So of these values, the deviation index, or DI, will serve as that immediate feedback to you, the technologist, regarding proper exposure. So it will tell you if you're right on. It'll tell you how much if you're off, and then kind of go from there. So we'll break down these terms in the coming slides. So the IEC, within the IEC standard, exposure index is defined as essentially the amount of exposure that's needed to create an appropriate SNR, appropriate signal to noise ratio. So there needs to be a certain amount of signal that's received for the system to actually be able to interpret that exposure event and to be able to make that diagnostic image. So you can see what these values actually are in this case, and how they really are set up. So it is considered to be the system is considered to be proportional to dose. So 5 microgray corresponds to an exposure index of 500. So we're not to be confused with the previous Kodak or Carestream system that also uses that EI value. So in this case, 500 is considered to correspond with 5, where 10 is corresponding with 1,000, 2 is corresponding to 200. So you can see how the system actually is considered to be a linear-based system with mass over essentially the dynamic range of that image receptor. So not as important that you memorize these particular numbers, but it does make sense for you to have a good understanding of the correlation, that it's a dose-driven correlation. So that number actually can mean something. You can interpret something out of that. Now, the exposure index itself can be influenced by a variety of things. So that could be part thickness, it could be artifacts, it could be SID, collimation, grid, centering, detector size, equipment, detector design. Those types of things can all influence that. So every body part will have its own unique acceptable range for what that EI value is, and that's why you're not going to memorize those EI values, because it's going to essentially, every part is going to be unique, and it's going to be derived based on the thickness of that part. So no need to memorize EI at this point, and that's kind of why I said earlier, DI, or deviation index, is going to be the most important thing. So this is just that general example, kind of going back and reiterating the importance of understanding how thick that body part is, whether that's through physical measuring or modern-day approaches, which are using computer software that kind of calculates what that patient thickness actually looks like. But we certainly should be looking at that to make sure that we adjust our technique so that sufficient transmission occurs. So it's all about transmission. It's all about how much the image receptor receives. It's about the signal to the actual detector. So just that same detector, different children, just general example, just to make sure that we child size our doses. So smaller children are going to use lower techniques to be able to have the same amount of signal needed to be able to produce an acceptable radiograph. Just to reiterate though, exposure indicator does not directly indicate patient dose. So dose is dependent on so many different things. It could be the projection, it could be the field size, it could be the part that we're exposing, it could be the organs that are involved. So whether we're exposing the breast or the thyroid or the small intestine or the femoral heads, all of those types of things, as well as grid use dictates our exposure, SID, filtration, tube output. So there's so many different things that are going to indicate patient dose. So do not confuse patient dose with the exposure indicator value. So again, exposure indicator or EI is just the dose that the detector receives. In this particular system, that number for EI would correspond to what that detector exposure actually is. So this conveniently brings us to our second term, which is EI sub T, or target exposure index. So what this means is that there is going to be a gold standard for each projection for each thickness. So those ideal targets, what is acceptable is going to be different for everything, every body part. So whether that's a chest, abdomen, foot, finger, head, you kind of name it, it's going to have its own unique value for what is acceptable. And what the system is going to do once we get now to the next term is it's going to take that target exposure index and it's going to compare it to the exposure that it receives. So it's a comparison between what we're saying is appropriate, and this value should be unique. It should be established based on the acceptable amount of model for radiographs that's determined by the medical physicist in combination with the radiologists and their needs. So these are just going to be managed by a database. So you're not going to have to memorize all of these EITs and say, okay, I got this EI. Now, how does that correspond to the EIT? No, the computer system is really going to store that information, and in the end, it's going to spit out a value to you that's going to be the deviation index. And that's where we're at here. So the DI, or deviation index, measures how far the actual EI value deviates from the projection-specific EI sub T. It's going to make use of this particular formula, and when you see log, it just means it's a logarithmic scale, so it's not a true linear-based scale, so it's not directly proportional. And we'll talk about what those proportional differences do look like coming up soon. But the technologist is going to have to specify the correct body part. That way the correct EI sub T is actually brought up. So it knows, okay, I have this EI, I need to correspond to the correct body part, which is considered, the optimal EIT for this particular projection. And then it has the ability to be able to calculate that DI value. So the clinical use of deviation index is the indicator of proper radiation exposure. The DI essentially is that immediate feedback to you, the technologist, regarding the appropriateness of your selected technique. So this is the super pertinent value. This is what you need to focus on and reflect upon. This is how quality is going to be tracked to make sure that we're using acceptable exposures on our patients per any given procedure. And this is how this logarithmic system actually works. So what we are striving for is a value of 0. 0 is basically, it means 1.0 as in terms of its exposure factor. It means it's a perfect exposure. It means that the EIT value and the EI value that we just captured on that given projection are a perfect match. The number is exactly the same and there is no deviation, hence the name deviation index. So in this case, what we're all striving for is a 0. There is no deviation. We had a perfect exposure. Then you can see there are some differences, and this is where the logarithmic scale comes in. So you can see that a +1 is a 26% overexposure, and a -1 is a 20% overexposure. So you can see that what that corresponds to, and it will be good to memorize this particular table. So 26% overexposed, 60% overexposed, 100% overexposed, 160% overexposed in this particular case. So we don't want to see any 4s, whether that's positive 4 or whether that's negative 4. But nonetheless, the positive numbers say overexposure. The negative numbers reflect underexposure in this case. So you can see 20, 40, 50, 60% underexposed in this case. So the accuracy of the deviation index does depend on certain factors. It depends, I'm going to say, most importantly on the accuracy of the physicists and their work to program in an appropriate EI sub t value, so that because that's what everything's going to be compared to. So there's going to be a lot of legwork to establish that database up front. It makes sure that our histogram selected, so basically we're comparing apples to apples, so we're comparing a PHS to a PHS. It's going to depend on colimation, so how much exposure, is our detector actually receiving, and then other factors such as, patient size, image receptor size, gonadal shielding can all have some form of an impact on this particular scale. So we should be now utilizing deviation index in our routine daily practice. This is our indicator. This is our quality control. This is what we should be hanging our hat on. This is what's going to tell you whether you're doing an acceptable job at exposing our patients to ionizing radiation. We, in essence, have a license to administer ionizing radiation, and we want to make sure that we administer the appropriate amount of dose. We don't want to overexpose our patients. Think about it in terms of, medication. A certain amount of medication is delivered to a patient over a certain amount of time. We don't want to give them too much medication. The same types of ideas apply to radiation. We don't want to overdose our patients. So we want to make sure we're doing our job as effectively as possible. So that immediate feedback is going to be essential. And really in practice, you should have very, very few images that hit +3 and very few images that hit -3, because think about, plus or minus 2 should be that system. And really when you go back, what does 2 mean? Well, 2 still means 60% overexposure. That is quite big. -2 means, 40% underexposure. So again, that's quite a large range of acceptability. So, I challenge you, if your facilities are making use of the IEC standard, be between +1 and -1 on a routine basis. And if you're not, figure out why. Are you not measuring effectively? Are you overestimating? Are you underestimating? Are you not adjusting your techniques? What is actually happening if you're using automatic exposure control? Is it the detectors are not over the part because the pediatric patient is too small, or what's actually occurring? The importance to make sure that we're holding ourselves accountable in the digital system. Yes, repeating exposures is very easy to do. So each time that we do that, not only are we double exposing our patient, but just think about, because of these systems and how they work, well maybe we were +2 on the first one and we failed to manipulate our technique on the repeat. So a +2 is a 60%, and then we repeat, and then it's still +2. That's another 60%. So in essence, we didn't just repeat that exposure once, but by dose, we have now exposed that patient to 3 times as much exposure as necessary. So it's equivalent to 3 exposures because we didn't take the time to actually adjust our techniques. So certainly going to be important. Exposure creep is a phenomenon that we'll really talk quite a bit about. So you'll have a good understanding of how that really can be a detriment to facilities, because as we increase our technique, that visual appearance becomes better and better and better. But it's not just about the visual appearance, it's about an acceptable appearance for a radiologist to make a diagnosis. So we have to make sure that we're using radiation responsibly in that nature. The other thing to think about, electronic cropping. Obviously we expose the patient, we should send that information over. Appropriate colimation should always be used, and it's not only just for exposing of healthy tissue to ionizing radiation, but it's also about the quality of the images that we're producing as well. So the term exposure creep refers to the gradual increase in our techniques over time for a given projection. So it could be, if you study this, you could just look at chest x-rays, or you could just look at knees, or anything that you select, and you can look at how those techniques are being adjusted over time. Exposure creep is a real thing. It's been reported for more than a decade to occur, and you kind of think about how long digital radiography practices have been out there. That's something that really needs to be noted. And if we are not paying very close attention to our deviation index, it's very easy for overexposure to go unnoticed. And when we talk about pediatric patients and we talk about their radiosensitivity, we need to be responsible in our actions. We don't want to overexpose those patients because they're living their life, with whatever exposure that is given to them. So we don't know the full effects of radiation and exposure. We know it falls within a stochastic pattern, so it's an all or nothing type of effect. Something may happen, something may not happen, but we want to make sure that we lessen our probability of something occurring. So in this study by Gibson and Davidson, really nice article. I encourage you to certainly read through that when you get a chance. They studied exposure creep from August of 2007 through December of 2009. And what they noticed in that period, which is a little less than a year and a half, they noticed that their overexposures in their department were increasing. Their optimal exposures in their department were decreasing. You can think, if they didn't intervene, these lines are going to cross at a certain point. The other thing to note is that underexposures are also decreasing over the period of this analysis. So that's really, honestly, it's really bad news for this particular facility. And what Gibson and Davidson did is that they did an intervention, and then they tested the results. So as part of their intervention, essentially they charged their technologists with documenting the exposure indicator value, documenting their KV, documenting their mass, and then the patient position as well. And then subsequently what they required their technologists to do was to go back into their system, see if this patient has had a previous study, and if they did, they were to use that information and to adjust those techniques accordingly if it was going to be that same projection that was going to be repeated again. So nice quality improvement measure. And what you can see here is because of that intervention over that study period now, so you can think, it took some time to install that intervention. But looking at that from February of 2010 through March of 2011, so just over a year in terms of the study period, what they have done is they have reversed the trends. So in this case, optimal exposure is increasing, so they're getting better in their departments. The amount of overexposure is decreasing, and the amount of underexposure is slightly increasing, which means that they're doing things responsibly. Of course, we don't want too much underexposure because of the impact of model, but the most important thing is that optimal exposure is being increased. In this case, when you look at this, there still can be some concern for a given facility in that still less than 60% of the images are considered to be optimal at the end of this study. So that means 4 out of 10 or 40% of these images are suboptimal, whether that's overexposed, which means that too much exposure for our patients. The image itself is not suboptimal, but we're certainly not applying the Alera principle. And then underexposure may result in a suboptimal image as well. So just kind of keep that in mind, that we would want this study to continue to go up, and then these numbers to go down, and really, underexposure to remain flat or even better control. So just to document a little bit more for the reasons that this was an effective approach, you can see again just in kind of the text-based recap of what we've already covered, but just know that we can certainly apply this kind of going forward. But instead of the exposure indicator value, we plug in our deviation index. So record your deviation index, record your KV and your mass and your patient position, and then kind of go from there. Look up that information when possible, and then adjust our exposure factors there accordingly. So overall, the objective here is really to ensure that we develop a standardized approach to the management of radiation dose specific to the exposure to pediatric patients, to make sure that we produce an image that is of appropriate image quality for the given clinical question. As technologists, we're really just charged with going back to the basics in some regard to making sure that we're looking at manipulating our techniques based on that patient thickness. So whether we're measuring that physically with calipers or whether we're using some type of digital technology to ascertain what that thickness actually is and manipulating our techniques then accordingly is certainly going to be important when you talk about pediatric patients where AEC may not be appropriate for that given projection. So certainly making sure that we incorporate the IEC deviation index as part of our standard routine, evaluating that, holding ourselves accountable, or perhaps a quality manager holding yourself accountable to make sure that those are done on a routine basis. So certainly considerations can be made for lessening exposure to patients prior to exposure. So whether we're talking about colimation during the exam, making sure that we're positioning our patients effectively to reduce exposure. We're using immobilization techniques. We're lessening our exposure time. Those types of things are all certainly possible. And then looking at the opportunities post-processing to say, okay, we really don't need a additional exposure. We have everything that we need. So these types of things need to be measured and monitored continuously, and it's certainly important to not just fully rely on the deviation index. There is going to be a visual assessment of image quality that's going to be needed. So, we're still going to have to make sure that we have sound positioning techniques that we're actually utilizing and applying. This particular tool is just one of those that helps you better understand a standardized approach to assessing that image. So looking at a variety of factors, it's called, the whole idea of this is called going back to the basics. So this basics tool is designed for us to look at the beam, look at the central ray. Is it actually fully aligned? Is it up, down, left, right at the actual center of the anatomy that we're trying to visualize? Artifacts, looking to make sure that we are either there are no artifacts on our image, or that we're making sure that we're evaluating that patient before the exposure to eliminate any potential artifacts, or we're watching our marker placements or those types of things, so avoiding repeats. We're shielding our patients effectively, so think every patient needs a shield, regardless of their age. Somewhere on the body can be shielded, so it's not just about the gonads, but breasts are actually considered to be the most sensitive structure, but there's plenty of other radiosensitive structures that we can also shield when it's not possible to shield the gonads. Indicators and immobilization. So really this just emphasizes the need to look both at the post-exposure criteria, which would be evaluating our deviation index, and then our during procedural factor is making sure that our patient is properly immobilized. Colimation, pre-colimation is always a must, so make sure you're applying that. And finally, when you're evaluating your image, just make sure that the pertinent anatomy is actually fully visualized in its appropriate orientation. Do you have the correct degree of obliquity? Is the patient lateral when it's expected to be lateral? Are we visualizing everything that we need to see? So if you remember to apply the basics as they're written here, that should be able to put you in the right direction to make sure that we are assessing both the deviation index and visually assessing for image quality to control our radiation exposure to pediatric patients. The sources for this presentation, both in part 1 and in part 2, are as followed. So you can see there's 12 particular sources on this slide. So if you have some time, go back and review these sources as well. These sources were also used for this presentation, so sources 13 through 22. Again, go back when you get some time, look at some of the research that's been done specific to exposure indicator research or specific to radiosensitivity in children. So a lot of great resources are listed here and on that previous slide. Finally, look at the imagegently.org website. I encourage each of you to officially and formally take the Image Gently pledge. It demonstrates your commitment to making sure that you're optimizing your exposure and your exposure parameters for each study, for each patient, each time, and that you're committed to making sure that our pediatric patients are given the appropriate dose for their growing bodies. And finally, this presentation was developed by a variety of imaging professionals, whether they be technologists, medical physicists, or radiologists. This interdisciplinary educational campaign was vetted by the following individuals. Thank you so much for watching, and I hope you've enjoyed the presentation.